I'm Kathy Taylor. I am the Associate Director and the Director of Global Health Training at the Eck Institute for Global Health here at the University of Notre Dame. I'd like to welcome you all to the session on global health and human well-being. I also want to give a special welcome to our Master of Science in Global Health students, so I'm going to take that privilege. We're all here today. And I know there are also students here from other classes, and a special welcome to all of you. I'll start today by introducing our panelists and another special guest that we have, a special discussant here today. Then I'll follow with just a few brief framing remarks, and then the panelists will have their remarks, and we'll have a respondent from our special discussant and make some time to have all of you engaged. I really want to have, a lively and open discussion. I don't want to eat up all of our time on the introductions, and introducing people of this stature and caliber and with this much experience is very hard to do well briefly. So I hope that as they're giving their presentations and you're hearing from them, that you'll understand that they all have an immense amount of experience in the field of global health. They come from different areas, and we have really a great opportunity to have different perspectives. So I'd like to first start with Serena Koenig. She is the Assistant Professor of Medicine in Harvard Medical School. She has been treating HIV and TB in Haiti for the past 15 years. Initially, she served as the medical director of Haiti programs for Partners in Health, and for the last decade, she has served as senior advisor to the Haitian Group for the Study of Kaposi Sarcoma and Opportunistic Infections. That organization is a Haitian NGO and the oldest HIV clinic in the world and largest provider of HIV care in the Caribbean. Partners in Health started in Haiti 30 years ago and has expanded to 10 other countries, with the goal of providing a preferential option for the poor. Dr. Koenig works with her Haitian colleagues to implement and evaluate kinder, more effective, and more efficient treatment strategies. Next, we have Dr. Bernard Nahlen. Dr. Nahlen is the Deputy Coordinator of the President's Malaria Initiative at USAID. Dr. Nahlen spent quite a bit of time in Kenya. That's actually where we met. He went to Kenya in 1992 as the director of the CDC Field Research Station in collaboration with the Kenya Medical Research Institute, where he led a group mainly working in malaria. In 2000, he was seconded from CDC Malaria Branch as senior technical advisor to the new WHO Rollback Malaria Initiative. At WHO, he led the monitoring and evaluation team as well as the malaria and pregnancy team. From 2005 to 2006, he was seconded to the Global Fund to Fight AIDS, Tuberculosis, and Malaria. And in 2006, assumed the position he has now as the Deputy Coordinator for the President's Malaria Initiative. And Dr. Sonia Sachs is a pediatrician, an endocrinologist, and a public health specialist. I'm skipping over where everyone went to school just for the sake of time, but please be assured that we have 4 physicians, and they all graduated with high marks. So Dr. Sachs practiced medicine for over 20 years, 14 of which she spent at the Harvard University Health Services in Cambridge. In 2004, she joined the Earth Institute, Columbia University, and became the Director of Health for the Millennium Villages Project, overseeing all health-related interventions and research. The Millennium Villages Project in 10 countries in sub-Saharan Africa is an integrated rural development initiative, a proof of concept that extremely poor rural communities can reach the Millennium Development Goals within a few years, and I think she'll be telling us more about that. Finally, our special discussant, which I'm very pleased to introduce, is Dr. David Addis. Dr. Addis began his career at the CDC and the U.S. Public Health Service as an epidemiologist. He's currently the Director of Children Without Worms at the Task Force for Global Health in Atlanta. He also founded a filariasis elephantiasis reference clinic in Haiti 20 years ago, which Notre Dame has carried forward over the last decade. In 2010, Dr. Addis was one of 10 leaders, including Jimmy Carter and Paul Farmer, who met at the Carter Center in Atlanta to consider the importance and impact of compassion in global health. Dr. Addis is an adjunct faculty at Notre Dame and currently teaches global health ethics to the Master of Science in Global Health students. So I want to just take a few minutes to lay some groundwork for our discussion. My own background is I'm a biologist, and I worked in research on infectious diseases for most of my career. I did live and work in Kenya for 14 years, so a lot of my perspective on global health comes from that experience. So just some thoughts about what is global health. This is something that doesn't seem like we should still be discussing or debating, but I think it's good for us to lay the groundwork on why the definition of global health is particularly important to the context of this meeting. It's a relatively new term that describes a relatively new field. Global health embraces a new way of thinking about and working towards a world in which everyone has access to health services, life-saving health services, and healthy lives that support individuals, families, and communities to live full and productive lives with dignity. Global health is rooted in the principle that all lives matter, that health is a human right. Global health emphasizes equitable partnerships and sustainable solutions. Partnerships should be based in respect and humility. The root principles of global health are absolutely consistent with the principles of Catholic social teaching, with the preferential option for the poor. Many of the global goals for health were previously delineated in the Millennium Development Goals, and Dr. Jeff Sachs talked to us this morning about how important it is to set goals, and I think that this is very relevant to what we might discuss in a little bit about some of the successes of global health because those goals were set. The goals were launched in 2000 and concluded in 2015. The follow-on to the Millennium Development Goals are the Sustainable Development Goals. I think for those of you who have been following the previous talks of this conference, we've talked a lot about the Sustainable Development Goals. I'm just going to quickly give the bullet points: to end poverty and hunger, to protect the planet from degradation, to ensure that all human beings enjoy prosperous and fulfilling lives, and that economic, social, and technological progress occurs in harmony with nature, to foster peaceful, just, and inclusive societies. And just as I mentioned, one of the principles of global health is to do this through a revitalized global partnership based on a spirit of strengthened global solidarity, focused in particular on the needs of the poorest and most vulnerable, with the participation of all countries. These aims were finally described in 17 goals that were agreed upon in a fairly long and inclusive process. And as some of you may have already heard, these goals were addressed in a speech given at the UN in September of 2015 by Pope Francis. And I know Pope Francis has been quoted a lot over the last half a day or so, but I'm going to continue in that tradition. Pope Francis said, "It must never be forgotten that political and economic activity is only effective when it is understood as a prudential activity, guided by a perennial concept of justice and constantly conscious of the fact that above and beyond our plans and programs, we are dealing with real men and women who live, struggle, and suffer, and are often forced to live in great poverty, deprived of all rights. To enable these real men and women to escape from extreme poverty, we must allow them to be dignified agents of their own destiny." He continues and says, "For all this, the simplest and best measure and indicator of the implementation of the new agenda," and when you're in global health, you're all about the indicators, so Pope Francis has actually given us some indicators, "will be effective, practical, and immediate access on the part of all to essential material and spiritual goods, housing, food and drinking water, religious freedom, and more generally, spiritual freedom and education. These pillars of integral human development have a common foundation, which is the right to life, and more generally, what we could call the right to existence of human nature itself." Global health is, as my friend and colleague David Addis says, a radical notion. The notion that everyone has a right to health isn't too difficult to conceptualize. It sounds like the right thing to do and the right way to think. But how do we realize this notion? How do we take these very high-minded moral concepts and apply it to the world of such stark inequity that we live in? Moreover, how do we apply it in ways that respects individuals' autonomy and respects their dignity, that respects their values? I'm going to ask our panelists to help us understand the successes, the opportunities in the future, and the challenges to building and crossing this bridge from these very high-minded theoretical principles to actually meeting the goals laid out by the SDGs and by the Laudato Si. So I will start with Dr. Koenig.
Thank you. I'm going to keep my, so I have 10 minutes? Is that what you want us to do?
10 minutes.
Okay, I have my iPhone here. So my work in Haiti involves really, all of my work has been at the patient level. Even my research is very focused on the patient level. So I'll start just by telling you a little bit about how I got involved in it, and then a little bit more about our current work. So I was not thinking about global health at all. I grew up in Seattle and I went to Boston for internship in internal medicine. And Paul Farmer was an attending at the hospital. And I met him, and he was very lovely and nice and a very good doctor. And he said, I have this patient in Haiti who needs a mechanical heart valve. Will you help me raise money? And I've convinced this cardiac surgeon to do the surgery, and then we'll bring him. So I said, okay. And you know, everyone wasn't, things have shifted in 15 years. That was about 15 years ago in the world. There were people who said, you know, that's a bad thing you're doing. You're threatening free care in Massachusetts because their hospital's not really making you pay the full price. And I was rather shocked. I thought, isn't our goal to save lives? I mean, so I met a little bit of that. Another, you know, Paul's a revolutionary. He was a bit of a head of preferential options for the poor for Paul really meant for everyone. So as he, at that time, Partners in Health was just in rural Haiti. And he wanted to find any way to help any patient. So we raised the money, and then he said, can you go to Haiti and get him a medical visa? So I went to Haiti, and I was very disturbed, distressed, shocked. I traveled around the world, but it's not the same. It's going into a clinic and seeing the patients and the problems that the patients had. And it's a 90-minute plane flight from Miami. And I don't know if you guys can hear me. Can you hear me in the back? So it was just extremely disturbing after having come out of a beautiful Boston hospital where you really felt like this is your patient, you need to help the patients, to then see people who had such a lack of access to care, even at Partners in Health. So there were more patients, and I just kept going back to Haiti to bring the hard patients, to find them Boston hospitals, basically. And then we took some surgical trips to Haiti. It was a very funny career path I had at the beginning. In fact, someone said, Serena, like, what is your career path? Taking surgeons to Haiti and bringing patients to Boston. But, you know, Sonia came to Haiti, and Jeff Sachs came to Haiti, and they saw the beauty of what Paul was doing in rural Haiti with the patients taking HIV medications. And it was one of the very first demonstration projects that HIV could be treated. And it sounds crazy now, but at the time, I went to the Harvard School of Public Health, and people were saying, I don't know, it's too complicated, can we do this? It was a very disturbing time. So after you guys came, it was awesome, and then you went off and were like the foundation of the Global Fund, and then we thought, well, boy, that was great. Let's get some drug company executives to come, and I will leave the company unnamed, but a very senior executive with Paul Farmer. Lots of rum and little Coke, trying to say like, hey, what about some HIV medications for Haiti? And Paul had a little hut, because he was living with the people. He didn't have a car, little hut, Paul's house. And this executive said, you should focus on clean water and food. You would be irresponsible to start HIV treatment if you did not know you could finish like for the rest of a patient's life. And I thought, where is that thinking coming from? Like, you don't say, I would love to give you chemotherapy, but I can't guarantee it's going to cure your cancer, therefore I'm not giving you any. I was thinking, I think the patient would just be very pleased they got to see their child go to first grade. I don't, like, why are we bad people for wanting to help people? And HIV kills you very slowly, generally speaking. You waste away, you come in. If you want to speak about undignified, dying of HIV is extremely undignified, as is dying of tuberculosis. So, Global Fund successful. Haiti was one of the first countries to get funded. and I was dispatched to rural Haiti as the HIV doctor. So Paul was in Conj and I was in Las Carabas. Really shocking and sad to be we were seeing the very first HIV patients in these communities with very advanced disease. So I did that, and then I came back to do an infectious disease fellowship in Boston, and I became very interested in research because I wanted to see, like, is this the best drug we could use? Is this the best way to deliver the drug? Is this the best timing for the drug? So Paul said to me, if you're going to do research, you better work with Jean William or Bill Popp. He's an extremely influential researcher and clinician. He's Haitian, and you can tell they're not fundraisers. It's GHESKIO. But this GESKIO is the oldest HIV organization, and it was formed before HIV had a name. And at the time, they were seeing these things, Kaposi sarcoma, and it was also under the Duvalier dictatorship, when you really weren't supposed to be talking about this at all because it was very embarrassing. The Haitians had been nailed with this. The Haitian hemophiliac, heroin user, homosexual, the 4 H's of the CDC. And so it killed Haiti's tourist industry overnight. In the early 80s, Paul Farmer's PhD thesis was AIDS and accusation, but how the Haitians got accused for HIV. And so the reason these guys are so focused on research is because they started out by saying, let's figure out why do Haitians appear to be at greater risk. And it turned out there was no reason. There was the same risk factors as everybody else. But because of that, that's really why they're so focused on clinical care and research. And so I have been working with these guys for the last 10 years. So let's see, I need to finish my points pretty quickly here. In terms of like life on the ground stories, I would say if you want to be successful in really achieving development, you have to support local organizations. GESKIO is a local organization. It's 400 Haitians and 3 Americans who've been working there long term. I'm one of them. Another one is a Notre Dame grad, and then one of Bill Popp's mentors from Koenig. Well, what kind of success can you have by supporting local organizations? I'll tell you this. From those days you guys were there were 2 places in Haiti that treated HIV, GESKIO and Partners in Health. We treated very few patients because we had very few medications, but we had patients that we were doing the best we could. There are now 143 clinics that are treating HIV in Haiti. The prevalence has dropped from 6.2% to 1.9%. Haiti is felt to have a very successful HIV program. Also, we have worked on tuberculosis a great deal, tied in with the Global Fund, and also tagged on to HIV. The 2 biggest providers are GESKIO and Partners in Health. GESKIO has a huge TB clinic because they're right across the street from the big slums. So I'll give you a personal story about how this has had impact. I'll give you just a short model story, and then I'm going to tell you the sad truth about where we are now. So, personal story. Kiki. Kiki was 12 years old when she came to us. She's an HIV orphan. She had drug-resistant tuberculosis. She and her sister, who was 19, were just trying to get by. She had all these abscesses popping out over her. It was extrapulmonary tuberculosis. And, she came to us after going to many other clinics. She was emaciated. And the pediatrician is Haitian. The thing is, like, they're all Haitians. They're not Americans who are there. Like, I'm a minority, and I'm bossed around by the Haitians. I accompany as, like, the lower level of a company where I'm taught as much as I ever accompany. But Vanessa really helped Kiki, and then Kiki was discharged from a tent where she had to live because the hospital had fallen down. She went home, and, she didn't take her drugs appropriately, and she relapsed. And she got drugs again, and she got new drugs, and she was treated with dignity. And her virus is undetectable for HIV, and her TB is treated, and she's now wants to start a company. She's 14 years old, and she wants to get connected to microcredit if anyone has any ideas. She's an optimistic and happy and lovely 14-year-old. She couldn't read or write. Now she's learning to read or write. So the thing is, you hear these stories and they sound dark and depressing. They're not dark and depressing. Kiki's happy. Her sister's lovely. They live a wonderful life. But they just needed the access to the medicines that were available. My second quick story is in terms of what are we doing with better models of care. We measure everything. PEPFAR, the George Bush U.S. initiative, has been very good about wanting to measure everything. And so in fact, at 5:30, I have a data safety monitoring board meeting because we have in thinking through like how do you deliver HIV care, we have a study we did it was Bill Pop's idea. It wasn't my idea. I wrote the study, but it was his idea. And he said, you know what? People need hope. The way we're doing things now is wrong in the world. You come in and you get an HIV test and you have to come back 5 times for all these counseling sessions. It's discouraging to people and they fall away from care, and a third of them drop out of care before they start AIDS drugs, and then many of them die. He said, let's do same day. And then Paul Farmer said, your mother better be okay in the standard group if you're doing this same day. So we made very enhanced standard care where they got everything. On the first day, you got an HIV test, all your lab tests, all your TB screening, your counseling session. Then you had a doctor visit at day 17, day 14, day 21. We started treatment on day 21. That was the standard group. That's not standard. That's like super enhanced standard. And the other group got same day treatment. And our mortality is half in the same day treatment. And our outcomes are better. So they want to publish early. That's our meeting at 5:30. But you see, that's a Haitian idea saying, but we could give people more hope. If you come into the clinic and you have HIV, that's a terrible thing to hear. But if someone rolls out the red carpet for you that day and says, it's accompaniment, we have medications for you, it's so important you take them, well, here they are today, it gives people hope. So I will end there with the slight caveat that we also had one question. Who is going to pay? So here I will say, we all agree Haiti has a very successful HIV program. It is under extraordinary threat. PEPFAR budget has been cut by 1/3. Our loss to follow-up rate has gone up extraordinarily. The economy in Haiti is tanking. The gourd to dollar was 40 to $1 at the earthquake. Now it's 60 to $1. So poor people have lost 1/3 of what their money was worth. People are leaving to go to the countryside. It's very, very challenging. The incentives are being cut out, transportation fees, food subsidies. So what I would say is global health is deeply under threat with the budget cuts. And HIV was a glowing success that is deeply under threat.
Thank you.
I was a minute over, sorry.
That's pretty good. Dr. Nahlen.
Yeah, it's kind of hard to follow up on that sort of passion. So thanks, Serena. I'm going to talk a little about my experience with a disease that actually kills you quite quickly as opposed to one that kills you quite slowly. So there's a little bit of correlation here between some of the challenges. First of all, it's great to be back here at Notre Dame. Professor Appleby and I were actually overlapped a while at Notre Dame back in the days of the dinosaurs, back in the 70s when we were both undergraduates here. So it's always great to be back here. And even back then, I think it's always been true of Notre Dame, and I'm sure it's because Notre Dame is a Catholic university, the sort of sense of social mission that was even then, students would go out on, during their vacations and stuff, to inner cities, it was always there. That was before sort of global health and international health may have been central to some of the thinking here at the university, but it's really great that this is now part and parcel of the way forward for the university and for the Keogh Institute and the Eck Institute and others that are working on this. It's great to see all the students here. So moving on beyond that, how did I get into what I'm doing now? I actually, after undergrad, spent a couple of years in Chile working with the Holy Cross Fathers, setting up an undergraduate study program there. And that's where I got interested in medicine, when you see what was going on at a very local level with people who, during very difficult economic times, who didn't have access to any sort of health services or access to health care. So I came back, spent a bit more time back here at the university taking additional science courses, went to medical school, did my residency working in California with migrant farm workers, which actually is where I first started seeing diseases like malaria and cysticercosis and some of these diseases that normally don't see in medical schools in the United States. And that's because of the nature of the patient population we were working with. Again, undocumented workers who had a perception they didn't have access to health care, but they actually did, because there were laws in California which sort of separated immigration services from the medical services. But nevertheless, people were poor. They were doing everything they could to not go to medical services out of fear, but when they showed up, frequently they had diseases which were pretty remarkable. I got interested then when I went to the CDC, when actually David Addis was there. Ended up working on malaria. And that's where I spent most of my career. And it was a bit frustrating, frankly, for the first part of my career, because we did a lot of great work showing what you could do for malaria, a disease which kills very rapidly. I mean, sometimes within hours, definitely within days if you're not treated and non-immune, and a tremendous burden on the health of particularly young children and pregnant women in Africa. Actually, I love this. I don't know who does the graphics for this conference, but I love this graphic. I was just looking at this little girl, it's just, whether it's in Africa or not, I was just, you know, she just reminds me of, well, she's one of the survivors, definitely, but this could be Africa, it could be sundown. I mean, at the moment, it's nighttime in Africa, and that's when peak malaria transmission is taking place, as most of you know. Back when I lived in Kisumu, it was frustrating. You know, a mother in a village in Africa, you know, malaria doesn't, your children don't necessarily get sick in the middle of the daytime when there may be a clinic you can get to. They get sick in the middle of the night. And again, these are very high fevers. Kids are very sick. And what does the mother do? Well, the mother and the fathers and whoever did everything they could to try to save this child's life. They would look in their house because they frequently would keep a couple of tablets of antimalarials from the last family member who was treated because they knew it was going to happen again and they wanted to make sure they had some drugs. If they didn't have that, they would go to a neighbor to see if there were any drugs. Again, this is usually the middle of the night. In the daytime, if the child were still alive in the daytime, they would go to a local clinic if they could get there, where there frequently were drug stockouts. They then would, if they didn't have any money, they couldn't go to a local shop and try to buy drugs. They would go to the traditional healer, et cetera, et cetera. So the parents were doing everything they could to try to save this child's life, and yet it was estimated year 2000, which is sort of the baseline against which we're working at, around 1 million children in Africa under 5 years of age were dying from a disease transmitted by a mosquito bite, which to a large extent was preventable and totally treatable. So it was incredibly frustrating to see this going on. I have to say, so, you know, what changed? Again, we did all this, I'll be prejudiced. We did some really good work. I was going to say great work, showing that insecticide-treated nets could save up to 1 in 5 children's lives in these villages, that the new drugs were pretty remarkable. They could actually change the course of the disease progress literally within hours, and yet there was no resources to do anything about this. I think what changed, and frankly, Professor Jeff Sachs, whom some of you heard this morning, when he chaired the Commission on the Macroeconomics of Health, sort of positioned health and reminded people that health is actually central to development. Malaria being one of the diseases they sort of focused on, and showing how failure to control malaria was actually having a huge negative economic development impact on communities in high transmission areas, particularly in sub-Saharan Africa, which actually created a different sort of dynamic and a different sort of dialogue, and it brought other people into the conversation because, obviously I'm a physician by training, having sat through some of the talks this morning and last night. I was thinking maybe I should have studied economics and theology along with that, but we are all motivated by different things, and being motivated by trying to save a life is, I think everybody can be motivated by that, but it's not always clear how different disease priorities sort of filter up and become global agendas and part of consensus building and where resources to fight these diseases come from. Serena mentioned the launch of the Global Fund to Fight AIDS, TB, and Malaria, which was a seminal turning point. And then in 2005, President Bush and the administration launched the President's Malaria Initiative, which was additional funding for malaria, sort of the corollary of the HIV, the PEPFAR program. It's been expanded under President Obama to today. We're in 19 countries and in the Mekong. So what's changed now? So the mother now, whose child may be getting sick tonight in Africa, in many parts of Africa, first of all, this is probably not, as opposed to a child getting 5 or 6 episodes of malaria in a year, this may be the first episode the child's had in the past year because there's less transmission because they're sleeping under insecticide-treated bed nets. And in many areas, and some of you are familiar with this, the mother can actually go to someone in the community, we have rapid diagnostic tests. You don't have to have a microscope. So people have been trained to actually stick a finger. If it's malaria, they actually have the drugs there. We're talking about very great drugs with a good safety profile. So you can actually prevent a lot of these children's deaths from bed nets, which now cost around $3.50 to $4 a bed net. And you can actually treat and save a child's life with drugs that cost around 20 cents. So that sort of commitment at many different levels, that it should be absolutely unacceptable for children, not just children, I mean adults too, but still the bulk of the severe disease and deaths was in children in Africa. It should be absolutely unacceptable for that to continue to happen. That has all changed. The Millennium Development Goals, and I agree, the Millennium Development Goals were, it was important to have one on health, and that specifically called out malaria along with HIV and TB. Well, we actually met the Millennium Development Goal for malaria. The overall WHO estimates for what's happened over the past decade is a 58% reduction in deaths due to malaria. We obviously can't rest on those laurels because there's still another estimated 435,000 kids who will die this year from malaria, so we still have a ways to go. So the point is that, and I think there'll be panels on partnerships and how these things happen, but there's such huge challenges in the world in general, but health issues are central to being able to free communities of the intolerable burden of HIV and TB and malaria. And if we fail to do that, it's going to be very difficult for them to develop economically. I'll just go into the economic development part of this. I'm not the macroeconomist or the microeconomist in this, but there are estimates. I mean, this mother I was talking about, there's lots of studies in Africa that up to 3 days of a woman's productive life are lost for each episodes of malaria because she's seeking treatment, or even if she is treatment, she's out with the child. And obviously, in areas where malaria hasn't been controlled, as I said, there are maybe 5 or 6 bouts of malaria in the year, and there's usually more than one child. So that's a huge negative economic impact on the productive life of women in particular in these areas. So when we talk about the new SDGs, malaria, it's not just SDG 3, which is one on health. I sort of went through the list. Ending poverty. It's estimated that for every 10% reduction in malaria transmission, there's a 0.3% increase in GDP. I don't know what that means because I'm not a macroeconomist, but it sounds pretty significant. The one on education, we know that keeping children free from malaria does result in better school attendance, better school performance. The whole issue of gender equality I've just referred to, because a lot of the brunt of what happens in these communities does fall on the women. And in the case of malaria, the main adult target group at risk are actually women of reproductive age who become pregnant, the negative impacts of malaria in pregnancy. Economic growth, which is climate. Again, malaria transmission is based on climatic conditions. So whatever happens, deforestation in Africa results in more malaria transmission. Increases in temperatures in some areas may be a good thing because there'll be less malaria transmission. In other areas, it's a bad thing because there'll be more malaria transmission, et cetera, et cetera, et cetera. So malaria is one of these that's very tied up into whatever the climatic conditions and ecological changes, and that's all based on the vector, because the vector requires, the vector is an animal that requires a certain temperature and humidity and certain ecologic conditions for breeding sites. So I'll just sort of stop there. Malaria, and it's not just malaria, we can use lots of diseases as examples, is sort of central to this whole discussion around human dignity and the option for the poor. I mean, malaria is a disease that actually has an option for the poor because it affects the poorest of the poor in rural areas. And it's almost like a canary in the coal mine. You know, if we are successful in continuing to drive down the burden of malaria, it's an indicator of all sorts of issues related to political commitment, to the effectiveness of our tools, and also to our ability to build up effective systems to reach these people, and the central importance, as Serena's pointed to, of the involvement of communities in this. Again, what's the big step forward is actually being able to empower communities with the tools they need to deal with the problem at a very local level. So thanks a lot, and I look forward to the discussions.
So that's actually a perfect segue for the point I would like to make, which is that my in-house economist, Jeff, being basically a quick study, listened to people like Serena. It was an incredibly formative trip with her and Paul Farmer. And he saw on his own eyes, and also got pneumonia on his own lung, that HIV can be treated even under the most poor circumstances. He learned from KEMRI, actually, we have to discuss this, KEMRI, where you were, the Kenya Medical Research Institute and CDC, how malaria is absolutely treatable, preventable, and treatable. And from other scientists and entomologists, the people who study insect, how the bed nets really make a difference. And so basically what he did, and I'm his amanuensis running behind, doing the needful, what he did is listen to the different people in the different epistemic communities, because just like these experts have the answer to these diseases, so do the experts in agriculture, in education, in infrastructure, business development. These things, the strategies on how to improve these circumstances that are fatal in Africa, let's say India and other places, that they actually do have solutions. The question was, one, how do you scale it? Which is why our trip to see your work, and Paul's was absolutely formative, just said, my God, you guys really know how to do this. Now let's do it for all of Africa. And the same with malaria. So scale is the big challenge for global health, because a lot of the individual solutions are there because of unbelievable expertise, such as here. Scale. And then the other is, why choose one sector as more important than the other? You know, because of the funding being relatively scarce in the international community, especially in health, a lot of the communities were fighting each other. The HIV people, got a little bit more attention and funding, partly because of loudmouths like Jeff and other people, but also because of the HIV activists. And then the NTD community that, David, you represented, the malaria people, that's how we know Peter Hotez, they were saying, well, why do HIV people get all the money when worms, almost everybody is infected with worms. You don't die of a worm necessarily, or not the typical helminth, but you get incredibly weakened, so you die of malaria that you wouldn't normally die of. So there was this infighting, and Jeff was basically saying, gentlemen, don't fight over the pie, let's increase the pie. So those were the two things. How do you focus on every aspect, health, education, infrastructure, and business development, rather than choose that, one thing is a silver bullet, that education of girls is the way to solve poverty. It's incredibly important, but if the girl, even when educated, dies of malaria, then it doesn't. So the challenge that the international community was facing, how do you scale from lessons learned in small showcases, and how do you do it for all of the basic needs of a community that's in poverty, which, since the problems come in multi-sectoral areas, the solutions have to also come in multi-sectoral areas, which is why I am weirdly enamored with the Sustainable Development Goals, because after, in health, I know a little bit more about health than the other sectors. In health, we've had almost 70 years of promises, commitments, rhetoric, Health is a human right. That was a major thing in 1948 because it was really the first time that the international community agreed. And we've had these statements and restatements and commitments of 0.7% of the GDP, but basically nothing has happened until the MDGs. But due to lack of time, let me actually skip to why I love the SDGs, because SDGs really speak to health people, because you don't have to explain to a health person, to a doctor, especially not to a pediatrician, that health itself requires food, education, infrastructure. You can have a perfect clinic, but if you don't have the road, the car, the telephony to call the car, and if you don't have the water, the electricity, and the food to keep the children and the mothers well nourished, forget the clinic. So we pediatricians don't need to be persuaded how important it is to think holistically, comprehensively, and that's what the SDGs are doing. And that's why I like them even more than the MDGs, which were transformational. But the MDGs have the SDGs have the advantage that, number one, they speak to all of us, not just those of us who live in poor countries, but all of us. And number two, they actually address the myriad of problems rather than just the MDGs, which were critical, only basically address the most core problems of poor people. And the SDG in health, which is the one I want to tell you a little bit about, to me is really transformational, because even though the MDGs was really terrific because it gave us goal-based planning, and those of you who went to Jeff's lecture this morning know that goal-based planning is our gold standard. Even though it had goals, it had a timeline. By 2015, we have to be X. And it had metrics. It did not have a comprehensive scope, and it did not have a how to implement the MDGs. And also it did not have how do you address the financial problem. And so the SDG 3, since Jeff will be quizzing you guys on what is SDG 12, what is SDG 17, you will remember SDG 3 actually does the following. Number one, it subsumes all of the MDGs, so it tries to finish the job of the MDGs, which is to focus on the unbearable cruelty and unfairness of child and maternal mortality in places like sub-Saharan Africa, for instance. So it addresses child mortality, maternal mortality, and then these addressable killers such as HIV, TB, malaria, parasitic diseases, immunization preventable diseases, diarrhea, pneumonia, etc. So it addresses those, but it goes further. It then adds on the non-communicable diseases, because people in Africa, just like people here, also die of non-infectious diseases, the cardiac arrest, the stroke, the car accidents, etc. So it includes the non-communicable diseases. And then it does the third thing, which is what I'm incredibly grateful for as a small actor in this public health thing, which is that it also addresses means of implementation, the how-to, and it actually also discusses, so it actually addresses, for instance, the human resource constraints, which is that there's an incredible lack of human resources in terms of clinicians in Africa. You hear these horrendous statistics of 1 doctor per 100,000, and it's really true. Where I work in 10 countries in sub-Saharan Africa, for the last 11 years, I met people 11 years ago, not now anymore, that have, basically most of the people I met have never been to a clinic, nobody's ever been to a doctor, but none of them have even been to a nurse. So there's an incredible lack of human resources. And then the other thing that the SDG 3 addresses is finances. So fine, you finally understand that you have to decrease child mortality, maternal mortality, this is how you do it, but then how do you finance it? And of course the goals can't explain everything, but they at least put out one premise, which is that nobody should become impoverished by seeking care, or to put it the other way around, nobody should not get care because they don't have the funding. And that's unbelievably important. So until recently, until the year 2000, it was all about commitments, rhetoric, and soon to be forgotten consensus and decisions. But in the last 15 years, things have really changed. I would say that one of the things that may have contributed to it is the MDG, the UN Millennium Project, which actually took these goals and said, okay, but how do we achieve the goals? And then we contributed with Sarah and other colleagues by doing this Millennium Villages project, which basically was saying, okay, we know what the MDG, we know what the goals are, we know how to get there because we know the epistemic community, we've told how to treat malaria, how to treat HIV. Let's actually show that you can do a multi-sectoral approach to health. You can address the basic food insecurity, you can address the basic health, education, business development, and infrastructure problems for $60 per person per year, which is 16 cents per person per day. And that's what we did. We worked until just a couple of months ago, it was the 10th year, with 10 incredibly poor areas within the 10 poorest countries pretty much in sub-Saharan Africa, and worked with the community. We did none of the work, with the community to address, basically to apply latest technology innovations and some tools to help address these problems. And the two things that I want to highlight from that, because I think I'm out of time, yes, is two things. One is you cannot approach health with these one-off interventions. You really require, and that we learned that also from Paul Farmer and Serena, which is you need a system of delivery. And so systems is really important. You need the brick and mortar of the clinics, you need the transportation, you need the terrain, the paths, but you need also the human resources, you need a drug procurement system, management, supervision, finances. You need a system and a data. In our case, we believe and have shown real-time data flow through the system. So that's one thing that we've learned. And by the way, we've put up health systems for 500,000 people on $40 per capita, 20 from the project and 20 from the country. So for $40 per capita, this is starting in 2004, so now it would be 80. But we've shown that you can actually address the basic disease and death burden in these poorest rural areas, remote areas, with a health system for $40 per person, or I guess the number you should remember now is 80. The last thing I wanted to tell you is that the SDG number 3 basically challenges us to really finally provide what we've been proposing but never really achieving, universal health coverage, that everybody has access, that needs it, everybody has access to health. And what we try to show in the Millennium Villages is that it's doable and very inexpensive, but you can't do any shortcuts, that there are really certain basic things that you have to do. But we did actually pull out one intervention, even though we believe in the holistic integrated health system being part of a holistic, multi-sectoral agriculture, education, business. But we did pull out one thing from the health system to accelerate the universal health coverage, and that's community health workers. I'm sure most of you know that in a lot of poor settings, there are these local community members who do their own field or do whatever their livelihood is, but they're also trained to recognize some of the common diseases and to try to troubleshoot or at least link to the clinic. And it's been shown that this kind of, or what Paul Farmer famously innovated, these accompagnateurs, who really make a huge difference in the lives of the people who are on HIV and therefore need to be taking medication every day without cessation, or with TB, where stopping actually increases the incidence of resistance. So it's been a known fact. What we decided to do is, because we learned from our 10 years in the Millennium Villages, that if you professionalize these community health workers, in other words, if they're not just volunteers who work on this out of the goodness of their heart or out of the little bit of social prestige that it gives them with their neighbors or out of the little bit of money that they can charge for delivering the bednet, that if you professionalize them, i.e. pay them, formally train them, formally supervise them, empower them with, in our case in the Millennium Villages for the last 5 years, with smartphones and a special application called, software app called ComCare, it's tremendously effective. And so since we learned it on our own in 10 countries, Jeff and I started, and now I'm running, sort of, or it's running me, a CHW campaign trying to accelerate countries finding ways to get both domestic resources and some external resources to invest into this least expensive, the smallest but critical component of a health system, not not to the exclusion of the rest of the health system, but that if you do nothing else, get these community health workers, still the people who live right in the neighborhood. They take care of 100 households around them, so they are acculturated. They know their neighbors, they know the social mores, but they are responsible full time. Whereas when they're volunteers, you can't blame them for not helping Johnny because they were in the field themselves, doing the harvest that keeps the community health workers' family alive. But if they're paid, then you can actually say, where were you on Thursday when Johnny was sick? So fully, properly employed and properly remunerated, supervised, which is made much easier by cell phone with georeferencing, so the manager really knows where you were and where you weren't. And we've shown that it's about $6 per person per year, which is minuscule, $6 per person per year to have this professional community health worker task force in countries such as in sub-Saharan African countries. And $6 is very little, but most countries in sub-Saharan Africa, their budget is such that their whole health budget is about $10. And so $6, albeit incredibly ludicrously little, is too much, and that's why we're looking for outside support. And just we've actually been able to help with road mapping of the different countries who are interested in what would it take to have a national community health worker task force. What would it look like? Who would they be? How much would they be making? Really defining what the program would be, how much would it cost, et cetera. And we actually were able to take one country, Ghana, and they decided to take us on faith value and take the leap of faith or whatever with us, and they have decided June 11th, I'll never forget, we'll go ahead and do a national community health worker task. And so they have put in their own funding, still needing a lot more from the outside, but they just put in their own funding from an unemployment fund that they had. And they have, from one day to the other, decided to put in 20,000 community health workers. And we're now working very closely with them to see how can you scale training for 20,000? How can you quickly teach and deploy cell phones for such a large cadre? How can you supervise? How can you make sure that the drug supply, that the medicines are available, et cetera, et cetera. And it remains to be seen. But I encourage anybody who's interested in health systems in Africa, or specifically community health workers, community health workers in Africa, I'd be delighted to speak to anybody who's interested.
Okay, thank you. I'm sure when the panel's over, you'll have a lot of students who will be interested in speaking with you. I'm now going to ask Dr. Addis for about a 5-minute response to what he's heard.
I can just stand here, is that okay?
Yeah, perfect.
Thank you very much. Can you hear me in the back? Great.
Not really.
Okay. Okay, how's that? Is that better? Great, thank you. Thank you, panel. That was wonderful. And so many of the themes that you've raised about global health, which is the field that I'm most familiar with, also resonated with many of the other themes we heard about global affairs. And while I'll be speaking about global health, so many of these themes have resonated throughout the day. I thought it was very interesting how each of you started with a story. A personal story of an encounter in Haiti, in Chile, or in Kenya. You came face to face with an individual who was suffering, or with a technology that was working, and you had this personal connection, this relational connection with human beings. And one of the challenges that we face in global health is this dual holding of the faces, as Bill Foege, former director of CDC, calls it, and the numbers at the same time. So Dr. Koenig works primarily with the individuals, whereas Dr. Nahlen is working with huge populations and USAID funding and budgets, and the means through which compassionate care is delivered has to embrace both the individual care and the global. And I think that's one of the things that we in global health struggle with, is how to hold both of those at the same time. And in Bill Foege's words, how to see the faces and the numbers at the same time. We have this problem of focus and scale, and I think that's one of the challenges, and one of the reasons why we need to stay in dialogue to remind each other. One of my favorite quotes about global health, although he wasn't talking about global health, is from Father Gustavo Gutierrez. He said, "Concern for effective action is a way of expressing love for the other." And so often in global health, we get so focused on the details, the mechanisms, the means of delivering services, that especially those of us who are working at the population level, that we don't see the faces. We forget the love and the compassion that animates that activity in the first place. And I think so many of us find that renewal of that energy when we go into the field and work with colleagues and literally see the faces. As you've heard, global health is very multidisciplinary. It's complex. It's not just physicians, although we have 4 physicians here today. It's much more complex, and if we stay looking at it just through a medical model, we miss most of the benefits that can be realized through global health. As you've heard, it's systems, it's dealing with global situations, global solutions to local problems. And it's by this love that animates global health action. It's taking on local problems and making them global problems so that they find global solutions. One of the things that's been most refreshing for me in global health in the last few years is this articulation of the preferential option for the poor, which I think all of you mentioned, and this engagement of Catholic social teaching as the underpinning of so much of global health work. And I'm really thrilled to have global health included in this conference and in the discussion of launching the school, because I think the ethical values and the spiritual values that are at the core of the school are those that are at the core of global health as well. So I'm looking forward to the discussion. Thank you.
Thank you. Thank you. So I'm actually very experienced in the incredible questions that our students can ask. I have some questions. I'm going to leave them by the side for the moment and give people in the audience a chance to pose questions, and we can go back. And I think there should be a microphone floating around. We have a question right here in the middle.
Hello.
Can I interrupt for 1 second? I would be remiss not to point out that the work on the community health worker that we have started 10 years ago in 10 countries was very much done in conjunction with my colleague that I was thrilled to see here, which is Dr. Jacqueline, actually has a married name now, Oluoch Aridi, who was our regional director and basically taught us everything that I know.
And Notre Dame is now proud to claim her.
Can everybody hear me? Okay. Then. Hello, I'm Jalen Carpenter. We've heard a lot today about how we're all in conjunction with these communities, with the environment, with our patients, with the people that we want to help, and the people that we feel drawn to help. Could it be that the big rift that's taking place in global health has to do with the fact that we as a whole are failing to stand in solidarity with these people? Because we come to a point where we have to ask, well, we shouldn't treat them if they don't even have water, or we shouldn't treat them if they don't have this or that. Is it the fact that we're not joining equity with solidarity holding us back from doing the best we can in global health?
Would anyone like to?
Well, no, I think that is an important aspect of this is, first of all, you know, there's, yeah, again, Serena had mentioned that HIV, the reason PEPFAR was launched was because of activism here in the United States on the part of primarily communities affected by HIV. I mean, we're all affected by HIV one way or another, but the actual people themselves who were HIV infected, once more effective treatment became available, just saw an outcry of how come we're the only ones benefiting from this, where actually the biggest burden of disease are in other countries and people are dying in large numbers. And that was a pretty remarkable thing, that in the midst of their own illness and their own suffering and tragedy, that they actually did exactly what Laudato Si and others would ask for. You know, we're all connected. They may have never seen these people in Haiti and others, but the fact that they actually, I mean, I actually worked on HIV for 4 years out in Los Angeles. I remember those days where people literally would block roads, they would chain themselves to conference chairs, they would do all sorts of stuff, they would go to drug companies, and that was an important point. This is a global crisis. We're all in this together. The private sector, the researchers, we all need to do something about this. And then, you know, the willingness of political leaders in this country and elsewhere to put some pretty significant resources to try to make that happen. And that sort of change, again, there is a threat to that consensus at this point in time. The case of malaria is quite a bit different. I mean, those of you who've lived and worked in Africa or are from Africa, it was a tragedy because most of the disease burden was not in cities and affecting politicians necessarily. They're in very rural communities, primarily affecting very young children who, like I said, the parents had a voice, but it was a very weak voice. They were beyond the extent of the healthcare system and frequently beyond the extent of the political system and politicians and them. And there wasn't a lot of activism, frankly, on behalf of what was going on. What changed there? Again, I think there were several things that changed, but it required a certain level of recognition that we should all, you know, the failure, any child dying from a disease that's to a large extent preventable and is totally treatable for pennies, that failure topples any other success we have as human beings. And I think, again, this is what Laudato Si and others are trying to bring. We're all in this together. It's all interconnected. So it's a different dynamic. I think malaria, frankly, when it came to the Global Fund, sort of rode on the coattails of the activism of the HIV, and we're very appreciative of that. But that's worked. It's been pretty remarkable what's happened over the past decade, and we hope that will continue to happen going forward. Why do the U.S. taxpayers bother to put money towards a disease which they themselves have never seen or don't feel threatened by? And, you know, the bottom line is there is a level of generosity of the American people which is pretty remarkable. And as I mentioned before, none of the politicians who are making decisions on U.S. taxpayers' money are going to win elections or lose elections based on whether or not they supported funding for malaria. People, a lot of what's happened, frankly, are faith-based organizations and others who actually went to bat for the poorest of the poor, the voiceless. I'll just wind up with one little anecdote. Senator Bill Frist, when he was a senator from Tennessee, I'd never met him, but I was in Kenya as the CDC director, and I got a call one day from Senator Frist. I didn't even know him, who happened to be in Kenya, because in Kenya and large parts of the country, about 50% of the healthcare is actually being delivered by faith-based organizations. And he had come out, a lot of these are like Baptist missioners from Tennessee, his constituency. And these are people who aren't just out there for a few months. You know, these people are out there for their lifetimes. And I have a lot of respect for these folks. He came out, he's a cardiovascular surgeon by training. People were telling him what a huge problem malaria was. And he knew nothing about malaria. So he actually called me out of the blue and said, could he come learn something about malaria? I said, sure. Well, Senator Frist later ended up becoming the Senate Majority Leader at a time when President Bush launched the President's Malaria Initiative, and he's the one who sort of shepherded funding for HIV and TB and malaria through so you never know how things happen, but, and sometimes things fall together in a way you don't expect, but we need to look for those opportunities and continue to remind people in line with the SDGs, in line with Laudato Si, we're all interconnected here. I mean, sometimes people are motivated by fear, whether it be Ebola or Zika. But we need to use those as opportunities to actually remind people about what this is all about.
If I could add to that, to those words of wisdom, it is true, though, that HIV has been ravaging Africa for decades, and the only time that finally it came to a crescendo and started being addressed is when it finally hit the west coast of the U.S. And the same story is now being, because, HIV started in
82.
No, that was in.
Oh, you mean in terms of when
in
the
Africa, it was, I
first
think,
cases happened?
1920s, they've calculated back.
There's
Anyway,
all
for
these funky studies. but
Decades.
it's
No,
kinda hard to know.
and millions of people have died, and we didn't talk about it, think about it, fund it, until it hit the shores of the United States. And unfortunately, that's a sad statement, and a slightly similar but much smaller thing is being played out now. There are people who are saying, how come when people were dying of Ebola, we did relatively little, and the little we didn't do very well. Whereas Zika, which is more in Latin America, and we feel more vulnerable because it's the Americas, they're getting much more WHO attention, organization, and promised funding. So that would be number one, which I think is a sad statement. But if I understood your question, the other thing was the multiplicity of addressing the problem with all of its manifestations. So I think you said that if you need, for a healthy person to survive, you also need things outside of global health. Obviously this is one of the reasons why I personally think that you can only address development if you pay attention to the basic 5 areas roughly of need, which is food production, health, education, infrastructure, which includes water, sanitation, etc. So I think it's very critical to look at the whole portfolio and not just choose one.
So I just have a quick caveat. I think there's something you're always battling in global health, which is the naysayers. Naysayers will pick anything they want to naysay. So cholera in Haiti, the naysay was against the vaccine. It was the Haitians and Paul Farmer who went and fought that battle, but they had to show that it wasn't too difficult to do 2 doses of cholera vaccine that cost $1.88 each, but they had to be refrigerated. And there were people who said, that's too hard, you can't do it. And why does Haiti have cholera? Not Haiti's fault, I'll leave it at that. In terms of Zika, we talk about Zika, but there's nothing happening for the women. So in the slums across the street from the clinic, they have nothing. They have no mosquito nets. They have only if the malaria program gave them mosquito nets, but many of them don't. It's urban. And they do not have mosquito repellent. These are day-biting mosquitoes. They have to go and work in the markets. So we talk about Zika, but we're saying let's research Zika. They're not saying how many women in Latin America are protected against mosquitoes. There's not really funding for that.
Yeah, no, it's just that the first 80 years of HIV in Africa, we didn't even hear the word, or no, it didn't even have that word.
Yeah.
But you're right, absolutely right.
And you have a lot of power. The thing is, if this generation of people stands up like not even as much as the HIV activists, just like a little bit, then you would be able to sweep things.
Just to add to that, the President Obama has asked for $2.8 billion for Zika, but it's in a political issue at the moment where Congress is saying, well, we're not use the unexpended Ebola funds for Zika. So we'll see where it goes, but it's not that people are totally ignoring this. It's just that the money's not there yet. Now, sort of aligning what you were saying, Serena, and I think Sonia also, this term sustainability, frankly, has been used in the past as an excuse to do nothing. That if you can't tell me up front, how it's sustainable, don't even start. And there continue to be people there. Unless you have it all figured out, unless you have it all sorted out, don't even start. Unless you can do everything perfectly. So this is an issue of excellence being the enemy of the good. And we're all in a learning environment, so sometimes you need to get started, see what works, what doesn't work, you recalibrate, and that's where we all need to be involved.
That's a great point. Let's have another question. Could you introduce yourself too,
Sure.
please?
I'm Meg Gallagher. I'm a senior here. And you talked a lot about research in terms of identifying the treatments and then funding and getting access to the treatments. But how can you ensure that people are taking and using properly and using the bed nets and finishing the malaria medications or the HIV treatment? Can you talk a little bit about your experience in the field or in the policy side of where you see that being effective or what can be done to make sure it comes full circle?
Community health workers, acompañadores.
Well, we're very specifically focused on this because I told you that for HIV, we actually have viral load. So if somebody, you can check someone's blood, and if there's no virus in their blood, they're taking their drugs. Now, if there is virus, they're either drug resistant or they're not taking their drugs. And so we focus on viral load, and that we know that things are going well. However, it is incredibly challenging to help people who live in chaotic situations to be able to take their drugs every single day. And if you miss the current first-line regimen that we use, if you miss just 2 days in a row, the virus can start to rebound and you can develop drug resistance. But what we're focusing on now is the delivery of care, that it can't be the same thing for every person. The World Health Organization is moving this way, and our thing we're calling rapid and personalized. So we like to try to pick out who is at risk of not taking their drugs based on their demographic variables of the first second they walk into the clinic. And then at the first time somebody's a few days late, we want to give you an individualized treatment plan where you sit down. You need to group the patients. So you have most patients who are going to take their drugs very well. They should be in and out of the clinic in 20 minutes to 30 minutes. Why are you making them sit on a bench? That's a bad thing for them to do. We extend out as many months as we can between your need to come and get the drugs. We try to think of new ways to get you the drugs to minimize the time required. Plus it saves resources. But then there's a subgroup of patients who have a lot of challenges. Those patients you have to handle individually, but they should also get to have a say in what's going to work for them. So you're right. If you're not going to take the drugs, it's not going to work. But people want to live. So therefore, I would say if they're not taking their drugs, did you not explain it right? Or are there barriers you're not aware of? Because really, again, people want to live. So if our systems are kind and good, they should be taking their drugs.
If I could just, when I refer to health systems, which is what I focused on for the last 5-7 years of the 10 years of working in rural sub-Saharan Africa, health system that we've shown that actually delivers for $40 per person per year at the $2005 is 100 households being completely the responsibility of one community health worker who then follows up on kids that they've identified were probably, were vulnerable or that they just returned from a clinic with a drug and to make sure that they're taking it, whatever. So 100 households, one community health worker. 1,000 households, which is 500 people roughly, a clinic. So my definition of a system, just schematically, is a clinic for 5,000 people, a community health worker linked to that clinic, communicating with that clinic for every 100 households, and an ambulance and a referral hospital for about 50,000. And that's what we've demonstrated is very feasible and actually addresses what your question poses, which is unbelievably important because you can put everything in place and then you could still have people who actually don't access for all sorts of reasons. The mother-in-law doesn't let the young woman in labor go deliver in the clinic because her son is not home yet, or because they're Fulani subgroup within, a bigger Nigerian, a minority in a community. There are all sorts of reasons why people, even in the shadow of a clinic, don't access the clinic. And even if they do, they don't necessarily follow through. So that's, by the way, one of the reasons, what you said is one of the reasons why Jacqueline and I spent so many years thinking about a community health worker who is held accountable for the well-being, survival, and well-being of 100 households, and being motivated by keeping them alive and well.
Let's try to get in one more question. Dr. Bolton.
Hi, Kat Bolton. I'm an anthropologist. I've worked for many years in Sierra Leone. And, as you know, the recent Ebola epidemic was absolutely devastating for the country and, wiped out the medical profession there, essentially killing almost 10% of the doctors. But my question goes to a sort of broader one about, when the U.S. committed all of these funds to fight Ebola, over half of them stayed in the country for drug development. And, Serena, you mentioned this in your comments that, getting Pfizer executives drunk, essentially, in order to get them to bring, antiretrovirals to Haiti. And that so much of the ebb and flow of disease burden in the developing world is sort of it hinges on decisions made in Pfizer's boardroom, whether it's, the availability of AZT or chemotherapy drugs. And, you all mentioned how the private sector sort of needs to get on board with this in order for us to have a future. But I would really like to press you to comment on how that would actually occur.
Pharmaceutical companies. I think government control of pharmaceutical companies, pricing. I mean, if you saw that very unkind man, Martin Shkreli, who increased the price of, I needed that drug for a patient in Haiti. So I would say it's very sad and frustrating, and I'm not going to be able to give you answers. We did just read an editorial in Clinical Infectious Disease, Bill Popp and I, that they just did a study saying if in the U.S. if we did 2 of these drugs, that instead of 3, that we could save like hundreds of millions of dollars in the U.S. And they asked us to write an editorial, and we said, well, this is a great study. But another point is, why is 3TC, which is pennies in Africa and FDA approved and all over the world, so expensive in the United States? And abacavir is also a generic drug now. So the generic drugs in the US are very expensive. Our point was, if you could just approach what we are doing with FDA approved drugs in Africa, all over the world, in terms of, FDA approved drugs for AIDS treatment, now that 2 of these are generic, if the US could just take a fragment, just be 10 times higher than the price in Africa, then you would have hundreds of millions of dollars that you could use to accompany the American people. So if you want to look at a sad drawing, it's HIV in the United States. You have the cascade goes like this in terms of the number of people who have it, the number of people who are diagnosed, and the number of people who drop out of care. So we said, but if you save that money, it should go into accompanying the Americans who have HIV.
And HCV is, I think, an even better example. We spent an entire 2.5-hour class period on this last week discussing pharmaceuticals and drug availability. So I know that the question really resonates with the class, and we didn't really come up with very good answers. And it is hard to link for-profit companies to this, for the social good drive that's needed for drug development. Did you want to respond to that?
Well, again, malaria is different because, first of all, it's good to have an anthropologist involved, because what happened in Ebola had nothing to do with drugs or vaccines. It had to do with community involvement and changes and understanding what was required to have an impact. Actually required behavior change involving understanding communities and their willingness to, what they were willing to accept. But having said that, sometimes we do need drugs and diagnostics. Malaria, there is no profit motive for anti-malarial drugs for most companies. There's no company in the US that makes anti-malarial drugs. So there's a couple of big companies, Novartis and GSK in Europe, who do, and they have a social sector within their company. So, as Bill Foege once pointed out, churches don't have a monopoly on goodness. There are people within these companies themselves who actually are trying to figure some of these things out. So Novartis and GSK, these drugs are now off patent, and a lot of them are being manufactured in India and China. But the bottom line is, it's an ongoing discussion with them. There will be a new class of drugs coming on, which will be more expensive initially. And again, I'm not the economist, but we do have people we work with on how you deal with market forces, and once you actually are able to scale up and have enough resource, companies want to be assured it's not going to be a big loser for them, but many of them are actually willing to. I'm sure David can give examples with the ivermectin distribution, mass drug administration, which is totally free. So it depends on what you're working on and who you're dealing with in the company and which companies you're able to engage, but it's an important area to stay involved in.
Can I interrupt for 1 second? Really quick, Ebola makes my blood boil because if you had community health workers who know their 100 households, who know what's going on, they would notice that all of a sudden, instead of the usual 1 per year bloody diarrhea, all of a sudden there's 1 per week, 2 per week. If we had community health workers being sort of the sentinel screeners for resurging or emerging diseases, we would know much before, whereas Ebola, we didn't know until there were bodies piled up in front of clinics. And so we all internationally said to ourselves, this just shows the failure of Sierra Leone's health system, of these very poor countries' health system. So we then work with Guinea president for a national scale community health worker. They put together a wonderful roadmap, a wonderful plan, put it to a well-known funder, and the funder said, Guinea is not our priority. We did give during Ebola. We don't really think that this is necessary. In other words, even after what all of us watched the horrors of Ebola, not only would we know earlier because the community health workers would have been there, but the doctors and nurses that were killed by going to a community and the community distrusted them, which I understand. Again, even that would have been easier if the support was provided by their neighbor whom they know. Even after all of this, I, who spent 23 hours, 7 days a week, cannot find even a blip of increased willingness to fund community health workers.
Okay, thank you. So I'd just like to take 1 minute to wrap up, to try to synthesize a little bit. There are so many things that we didn't get a chance to talk about, and I do regret that. So the Keough School, please have us all back again for more discussion. You know, global health addresses issues for which global cooperation is needed, and there actually has been a lot of progress in the last 15 years. So for those of you that are just getting involved in global health now, it may seem frustratingly like a bad situation, but for those of us who have been around for more than 15 years, there's actually been quite a lot of progress, and there's been a lot of investment that was mainly driven by the Millennium Development Goals. I think part of the frustrating part of global health is that we find these solutions, they can be implemented at a local level, and they're funded at a local level, and we talk a lot about scale. The question I think is still out there is how can you really scale these things, and where will those investments come from? So that will be a huge challenge for global health as we sort of come closer and closer to some type of equity, around the world. So I want to really thank our panelists and Dr. Addis and all of you great participants for your questions and for listening today.